All right, welcome everyone to Being Patient's Live Talk. And today we'll be talking about a long-running study of people at risk of developing Alzheimer's, known as the Wisconsin Registry for Alzheimer's Prevention, short for WRAP, as well as the documentary Determined, which features the stories of three WRAP study participants who lost their mothers to Alzheimer's, along with insights from experts involved with WRAP. So today we'll have Therese Barry Tanner, producer of Determined and a participant of WRAP. And she is joined by WRAP's principal investigator, Sterling Johnson, as well as Gina Green Harris, director of the Wisconsin Alzheimer's Institute Regional Milwaukee office. So thank you all for joining us.
Thanks for having us.
Thank you for having us.
Thanks. So, Therese, I wanted to start off with you first because you have been personally affected by Alzheimer's disease in your family, and I wanted to ask if you could share with us your late mother's journey with Alzheimer's, and what were the early signs and symptoms that she experienced.
Sure. In the early 2000s, a couple years after their 50th wedding anniversary, my dad started noticing memory issues that were manifesting themselves really in language, the inability to find a word at the end of the sentence. And he waited a while before he contacted me. I lived 40 minutes, not too far, but far enough. So I visited a couple times and was able to see what was going on. And we didn't do anything right away, but additional issues started to kind of crop up, including more than just the finding, the end of the word at the end of the sentence, other slight memory issues. So I talked to my dad about seeing a specialist, which was a neurologist. So we took her in and, they do a very short version of a memory test clinically. She didn't do very well, but she didn't do, it was the early stages. So she saw that neurologist, over the course of, it's hard to remember the timelines. And then we heard of a different neurologist that had a more patient-centric touch especially with this type of disease, and we switched. And that neurologist did an MRI. And through that, they were able to see the size of her hippocampus and how small it was. And that was through that technique at that time, she was able to say that she thought it was probably Alzheimer's disease. And, the symptoms as time progressed really manifested themselves in that way.
Right. And at the time of the diagnosis, it was early stage Alzheimer's. Is that correct?
Yes.
Yeah. And what was her reaction, and what was your reaction to the diagnosis? And
I suspected the diagnosis. I did something that probably is questionable in retrospect, but knowing my mom, I thought it was better not to tell her the diagnosis. She's a lovely person with so many virtues. But one of her sort of dispositions could be really fixating on negative things. And I just felt that wouldn't help her at all. And that was probably a pretty big decision to make. The rest of the family went along with it. And so we did not tell her. And while it may seem odd to all of you and maybe to people listening to this, we felt it was the best decision for her situation. And I don't regret that. I think I think it probably was. I don't think she would have understood it, and I don't think it would have helped her.
Got it. And I was listening to your interview with Alzheimer's Speaks, and you were talking a little bit about the caregiving journey and you helping your dad out as well during this journey. And you mentioned that your family felt like there was no place to go outside of the home, which was very isolating for your mom and the family. Can you tell us more about why your family felt that way?
Well, I mean, perhaps there were more resources that we just were too overwhelmed to check into them. So I have to say that. I think at the time, it's so new and so scary, and you don't know what to do first, and you don't know which foot to put in front of the other. It's overwhelming, and so I do remember making a couple calls to the local Alzheimer's Association. I can't recall the specifics, but we didn't pursue resources, and I'm not sure how many were out there. So what it really meant was, as she got worse, I mean, I would go down and spend time there, and I would try to take her out of the house so that my dad could, get a break, or be with her there and he could get a break. But it was, in the beginning, it was easier. I felt it was better to try to take her out, because then she would have some additional outside stimulus. I remember taking her to a coffee shop, a place, where we could be across the table from each other and chat and just be with each other. And that worked out okay for a while. I also remember trying to help her shop for clothes, as her, I can't remember if she gained weight in the beginning or lost weight, but some of her clothes didn't fit her, and that was very hard. And although necessary, very difficult to go into a department store. I think it was Kohl's, and the dressing room, and trying things on, and all of that. So it just didn't. It got to be so difficult that we had to stop doing it.
Right.
Basically.
Right. Yeah, and I think that how difficult caregiving can be for you is a feeling that many family members feel as well, right? And I mean, your documentary really highlighted that, especially with Barb's experience as a caregiver for her mother in the late stages of Alzheimer's, right? And there were some very personal and intimate scenes in those segments of the documentary. So yeah, I think I wanted to ask you also is, then what inspired the documentary Determined then?
It was, my mom passed away in 2008. It was 2011. And I had a full-time job at a large corporation, and we had some ups and downs with, the way things go there. Sometimes they expand, sometimes they contract staff, and it can be unnerving. And so I kind of when I came home from work, I left my job, my work at work, because I felt that was best for my own emotional well-being. And for some reason, I let my mind wander. And I also talked to the study coordinator at that time about my own experience being a RAP participant, which, unlike Gina's office, the rest of us aren't that connected except for semi-annual sessions with the researchers where we get updates. So you go through this journey in these other locations kind of by yourself and, in your own head. So a discussion with that lady plus my creative mind wandering led me to a thought about trying to tell the story of Alzheimer's disease in a different way. And, I've been doing a lot of reading on it and had my own experience. And some of the things I heard in the news during those years was that a cure was just around the corner. Very often I heard that. And from my participation in the study, I knew that that wasn't the case. So I wanted to tell the story of the disease more realistically, and from the perspective, I thought it would be interesting to tell it from the perspective of two prongs, where the research really is and where it's going, but through the eyes of people involved in the research who've had the experience of caring for their parent. And that was the idea. And I was able to get the right people and the right okays. There's more to that, but to answer that question in short, that was how it came about.
Right, right. And when you were like brainstorming about the documentary, you were already a participant of RAP, right? So what motivated you to join RAP in the first place, and how did you find out about the study?
They did, while I was in the early stages of my mom's diagnosis, the former principal investigator did a talk as a part of a lecture series on dementia at one of the local hospitals where my parents lived. And I thought it would be a good idea for my dad and I to attend those sessions to learn more. And the second or third session was an overview of dementia given by the study's then principal investigator, Dr. Mark Sager. And I took furious notes during that, and he mentioned the study, and I followed up on that probably with 4 to 6 months later, and joined the study in 2004 because I thought it was a way of doing more than, caregiving obviously was important, but I thought it was such a positive thing, positive feeling to join that study. I actually could do action that might make a difference. And I've talked to other RAP participants. That's a very common motivation, very common.
Right. Yeah. And participants of other studies have told me that as well, right? You're part of something that's meaningful and purposeful. So that's a big motivation for people. And Sterling, I wanted to take the questions over to you then. Can you talk about, what are the main objectives of RAP?
Sure, yeah. RAP has been ongoing since 2001 when Mark Sager put this together, and the main objectives then are pretty much what they are now, which is to identify this disease as early as we possibly can, before the symptoms occur even, and then to identify what it is that might render a person more at risk or more vulnerable to getting this disease, or more protected from it. What are their what's their background? What's their medical situation? What are their genetics? What sort of health and lifestyle factors might influence whether this disease manifests itself? And so those are the major goals of the study, and that's pretty much been a fixture of this since it started way back in 2001. But now, of course, we have the mechanisms and the methods to actually accomplish this goal.
Right. And yeah, and who are the participants of RAP? Then can you tell us about, the basic profiles and demographics of the people in the study then?
Sure, yeah. First of all, I think the most unifying demographic feature or quality of our participants is how dedicated they are. They're, as Therese just mentioned, they want to make a difference. They want to find an answer. And so they are committed to this study. But the average participant started when they were about age 54, which is midlife. And we know that the average onset of dementia is somewhere in the late 70s. So on average, these people are going to be about 20 years, 25 years or more before the typical onset of dementia. if they're destined to get dementia. So the average age right now of our participants is about 69, and we have about 40% that are hypertensive. We have about 40 to 42% that have high BMI, body mass index. There's a good chunk of them that have high cholesterol, and about 10% have diabetes. These are reasonably typical numbers for this age demographic, for these age-associated changes that happen in their health. They are about 39% of our participants have this particular risk factor gene called APOE, and they have the E4 allele, or the risk gene of APOE. So that is an important feature. That means this cohort is enriched with risk for Alzheimer's. When we started it, we had no way of knowing who had it, and we still don't know who has it and who's going to get it. But we can go well beyond genetics now. So another key feature that is important is that about 25% of our participants have amyloid in their brain. And we haven't imaged everybody, but of about the 400 that we have imaged, that seems to be the rate of amyloid positivity, about 25%. And so that's important information. That means 75% of our participants don't have signs of Alzheimer's disease proteinopathy, at least not yet. We hope that continues.
Right.
So that gives you hopefully a sense of the overall demographics and the characteristics.
Right.
One other important thing I'll just mention is that we have about, I think it's about 16 or 17% that are from underrepresented groups who are Black or Hispanic. And we'll talk more about that with Gina.
Right. And most people have a family history of Alzheimer's.
Thank you. Yes, that's an important characteristic. Yes, about 72% have a parent with Alzheimer's disease, clinically diagnosed Alzheimer's disease, just like Therese.
Right. And yeah, and like, what are the expectations of the study then? Like, what do they do?
They come in every 2 years and they undergo extensive cognitive testing. They allow us to draw blood from them, which we do some regular standard labs, but most of it we put in the freezer for an opportunity like is starting to unfold in our field for these blood-based biomarkers. So we have blood in the freezer going back to way back when, back to the early 2000s. So also at their visit, they will have a fairly large packet of surveys that they fill out that asks about everything from stress to their eating habits, to their physical activity, to cognitive activities, sleep, and other things. What else? We invite them to do sub-studies when they come in, imaging-based studies or other studies of interest to them, including things regarding more direct measurement of their physical fitness levels and measuring certain chemical profiles like cortisol, things like that.
Right, right. And Therese, so you've been going in for the clinical visits every 2 years for quite some time now. Is that correct?
Yes.
Right. And how's that experience been for you?
You're going in for this battery of cognitive tests. It's hard not to be nervous about it. You're only being measured against yourself, but everyone I've talked to in the study just naturally has some anxiety around it. It lasts a couple hours. I don't know what the exact time is right now, but it's close to 2 hours at least, and that's a long time. It really is taxing, and the basis of the testing is that there's not a stop point, but you stop in each section when you can't complete it any further. So it's not something you really look forward to, but you do it because you're dedicated and you want, to make a difference. You want this rich data with this study that can be analyzed the way it has, such that, great papers can be written about the insights. And the questionnaires that Sterling mentioned, I didn't, they tell you you're going to get a packet in the mail, but I remember the first time getting those packets, and it was unbelievable because they ask you almost every possible thing they can about you, including that he mentioned, some of the key things, but your employment situation, your educational situation, it's an extensive list. And I was surprised. I remember being surprised by that. I didn't quite schedule enough time the night before my first visit, and I was trying to do it over dinner in Madison. It wasn't a very good idea.
Right. And Gina, I wanted to take it to you now then in terms of recruitment efforts for RAP, because getting enough participants from underrepresented communities is really important. Can you tell us more about your thoughts on why African Americans, broadly speaking, are underrepresented in Alzheimer's research? Like, why is that the case?
Yeah, so I think interestingly enough, as was said, everyone understands that, particularly with Alzheimer's disease now, if you've been impacted by it, it's really important for you to participate or to at least learn about the disease itself. In learning about the disease, sometimes just participating in research, you just don't have the time, especially when you're in the trenches. And so when you think about communities of color, underrepresented groups, and as Therese has described the taxing burden simply of the disease itself, and then you actually add into that the lack of or the misunderstanding of resources that are available to you or access to those resources, and then triple that with the mistrust of systems, there you have a perfect storm as to why people don't have time, don't have capacity, and quite frankly, don't trust systems. So there is a underrepresentation of people of color who are participating in research for those reasons. But then there's also the flip side of it to say, how are we actually creating opportunities that show value to those communities that they need to be participants in research, right? Are we making it accessible? Are we making it realistic? A 2-hour battery for someone who's primary caretaker, has a full-time job, has all of these other challenges, may not be optimal. But what we do understand is that, again, it is essential for us to participate. And so what we've been doing in terms of recruitment is really working with the community to say, what are the best mechanisms to reach the community, to engage the community, right? And then support them. So as I listen to what both Therese and Sterling have talked about, we've really taken the time to back up, help the community understand the science of Alzheimer's and dementia, particularly in underrepresented groups, right? We have some of our values, our belief systems are a little different about memory issues, right? We don't necessarily understand some of the physiological challenges or what Alzheimer's disease is doing to the brain in real time, literally, right? And we think of it sometimes figuratively, right? And as opposed to saying, no, this is a disease that is actually eating away at the brain, for instance, as opposed to it being something that's just mental health or something that can be handled with the DSM. We really had to get the community to understand and physically see that Alzheimer's disease is not just a name. It is actually something that is impacting the life of their loved one and their individual. And it's not something you can just wish away, think away, pray away, but there are some real important caveats here. And so once we started talking to the community in real time, bringing scientists such as Sterling to the community to have real conversations, ask real questions, people began to understand the disease better. That's really, I think, was one of the biggest barriers the lack of understanding, and then accessibility to get good diagnosis, right? And understand what those mean. So we really have done I'll say just our homework of figuring out how do we help the community understand not only the importance of research, but what this disease really is and what it's doing, so that we can transition our thinking around it from thinking that it's just some kind of mental illness to understanding it's bigger than that.
Right, right. And, building a relationship with the community is important. And like better education about like the basics of Alzheimer's and bringing investigators like Sterling is one part of that in terms of building relationships, right? So like, are there other other initiatives that you can share with us in terms of in this process of building
Absolutely.
relationship?
Absolutely. So relationship building, I want to be clear to your listening audience that relationship building is not something that happens overnight. I will be frank and say, I thought about listening to Therese, and when we first started building our relationship in the community, it was around 2008 or 9. And the community actually was, we don't want to hear about Alzheimer's disease. We don't want to think about this thing. And what we do in 2021 is people are saying, let us understand this better. But what we had to do was, you're right, create an educational platform. But that platform had to be something that was not so sciencey that people couldn't understand it. It had to be real talk, real time. It had to be so simple as saying, how do we talk about Alzheimer's? What do we call this? And in communities of underrepresented groups, everyone wasn't calling Alzheimer's. That was not necessarily something that was translating well, especially in our Hispanic community, in our Black communities, in our Native American communities. So we started using terminology that the families developed, which was, dementia felt better for families. So that was a way that we began to educate the community by using dementia, but it also gave investigators a new language they could use. They already knew what dementia was, but if it felt comfortable for the community, investigators now could say, instead of saying Alzheimer's, they were saying dementia to the families, right? They were meeting people where they are. That's our motto, meet people where they are. So we did education from A to Z, all the way from getting an understanding from diagnosis, all the way through caring at home, understanding what the stages would look like. And not everybody's going to be a cookie cutter stage. That was also important, understanding the types of dementia. So we did that. And then we developed, as we learned, we developed more programs. So what I mean by that is we actually created a dementia wellness program, a lifestyle intervention program for those who we knew were high risk. And who were those high risk folks? Sterling described them to you perfectly. They're part of the RAP participants. They are folks who are hypertensive, people who have diabetes, people who we know have these other health, social determinants, health challenges. So what we did is we went upstream and created a dementia wellness program that helped people read labels, understand your diabetic numbers, help you reduce your hypertension, right? Walking clubs. We designed and developed with the community programs that they would embrace across community, keep them safe, but actually hopefully help reduce their risk. And in doing so, the community embraced us by saying, this is helpful for us. How can we give back? And the same is with the Amazing Grace Chorus that most people know. It started with super support, by the way. We're funded strongly by philanthropy dollars, which is critical to our work to do this engagement piece, right? Bringing the science and engagement together. And so we were able to create a chorus of folks who were living with dementia and their caretakers to have this positive experience. We learned this program through NYU with Dr. Mary Middleman, but we made it our own and we grew it within our Wisconsin network. It started in Milwaukee specifically for urban and inner city folks, but it has grown to everyone. It's suburban, it's anyone who's touched by Alzheimer's and dementia. And what we have learned through that program is we've done this wraparound for these families, one-stop shop. We go to them. When we think about what Therese is saying, people can't afford to pick up the phone. We have to actually pick the phone up for them or with them. We've got to we meet people where they are. If you're at home, we meet you there. If you're at a family reunion, we meet you there. If you're at a hospital, we meet you there. Mm-hmm. Because of that, I think we've been able to create this presence of care, support, and service which have really built the community's trust in us, but also understanding that we want more than you to be enrolled in this research. We want you to be actually safe, healthy as a caregiver, and as healthy as you can be with dementia. And as a result, I think people have been really saying we want to participate and help and give that essence back to this work.
And just to clarify, when you say we, are you referring to the WAI regional Milwaukee office in terms
Yes,
of?
I'm sorry. I always think everyone knows us. And so, yes, so the Wisconsin Alzheimer's Institute regional Milwaukee office has made that commitment. But I want to be clear, we have partnerships with everyone, right? That's the beautiful thing about this. So the WAI and the WAI as a whole in our Madison home base and the WAI regional Milwaukee office has really made a considerate, concentrated effort to be collaborators with all partners who are working in the Alzheimer's area. That too has been an awesome resource for us and really a win for us because we collaborate, but more importantly, we also facilitate. We facilitate through the network of the clinic network. We're helping providers understand dementia better, how to care for their patients better, how to be better trained at identifying which we knew was a problem, dementia. But we have done multiple things across the spectrum with hospitals, with community-based organizations, with grassroots, with faith organizations to really bring this critical disease of Alzheimer's and dementia into the face of the community through their lens. And so that can only be done through partnerships. But the programs that the WAI has developed, I want to be clear, have been successful because of partnership with organizations, but most importantly, partnership with the people who we knew were the end users. Right. And that also is our community advisory board, which I can talk about, which actually helps when you think about research, inform the research. The investigators such as Sterling and others off our UW campus come and talk about what's going on with Alzheimer's. What do you see? What do we need to do differently? How can we be of service? But on the flip side, they're giving them new and cutting edge information that the CAB can now use to now go into the community and be a real credible source of education for these families and support. So yeah, we have been doing these programs again for the last 13 years. We're going into homes and we're doing it in an ethical way. And more importantly, we're meeting people where they are.
Right. Yeah. And I wanted to just cite a statistic that you gave in a virtual presentation from last year is that when RAP began recruiting in Madison, Wisconsin in 2001, and by late 2005, only 6 of the 711 participants were African Americans. I was wondering, why was there such a large disparity then at the time?
Yeah, and so Sterling can speak to this too, but really what happened initially, and again, I want to be clear, recruitment of all people I believe was always the intention. But what we started, and when we started the program, when the RAP initiative was started, it was started inside of memory clinics in Madison, quite frankly, Dane County. Unfortunately, Dane County is not necessarily such a large Black and Brown community, and particularly those clinics that they were starting their work in. We also utilize things such as the UW alumni groups, right? Well, we know that there's small percentages of people of color there as well. And so what happened was, and like a lot of programs, we had the intention and the thought that everyone should be included. How do we reach those people? We weren't quite sure how to do that. And so at the early onset between 2001 and 2007, we really used that hospital-based model, that clinic-based model for recruitment. Then in 2008, as the numbers, as we began to create the office in Milwaukee, and we started with a small pilot to see if we could do education that would increase research opportunities for the Black and Brown communities. Well, then we started this whole new notion of asset-based community development research opportunities. And at that point, we flipped a lot of the work from inside the clinics into the community, which were then broadening our strokes, right? And putting that, casting that net much wider, where we were able to then reach the communities that we knew were heading to be the more high risk communities. And so I want to be clear, I think the initial intent was always to have multiple communities. How we did that, we just used the wrong resources to do. I won't even say the wrong, we just used resources that were at our fingertips that felt right at the time, right? But we
Right.
knew we had to expand that. And when we recognized that as a institute, we did something about it.
Right.
But
I mean,
what Gina
research
did there was when she came on board, her leadership and her vision were really key to that transformation. And we're not where we need to be yet, but we are so much further down the road of having a diverse study so that our conclusions and results are applicable to everybody. So
Right.
Gina, thank you, and kudos to you and your program.
And Sterling, I wanted to talk more about some of the recent findings from RAP, and I want to focus a little bit more on, the biomarkers of Alzheimer's. And I know, one of the main objectives of RAP is to, understand when plaques and tangles that define Alzheimer's begin to form, right? And you mentioned this in your virtual presentation last year. And there are recent findings published last year by you and your colleagues regarding amyloid and tau PET scans. But before we go into that data, can you briefly tell us what amyloid and tau PET scans are and why are they important for patients?
Amyloid and tau PET scans are really informative, vital ways of understanding whether plaques and tangles are present in the brain. And amyloid plaques is one of the key features of Alzheimer's disease, and neurofibrillary tangles composed of tau proteins are the others. So there's these two proteins, and they both have this property that they self-aggregate, or they clump together. Amyloid clumps with amyloid, tau clumps with tau, and they form plaques in the case of amyloid, and they form tangles inside of the neurons, the brain cells, in the case of tangles. So these are the culprits that cause the neurons to eventually die and for the symptoms to eventually appear. These proteins become abnormal many, many, many years before the symptoms appear. In some cases, in one case that we've observed, it looks like close to 30 years before the symptoms. And in other cases, it might be 5 or 10 years before the symptoms. So there's quite a range. And why that is a big focus of our study now. But yes, amyloid plaques and neurofibrillary tangles are the two key pathologies. The way we can get at these with PET scans, PET stands for positron emission tomography. And what happens with these PET scans is that you inject a small amount of what we call a tracer, a radio tracer, and it's a little compound, it's a drug that its job is to go and find its target. And in this case, the target is amyloid. And in the case of a tau PET scan, the target would be tau. It goes and finds its target, and it's a really feat of chemistry for this to even happen, because it's got to get through the blood-brain barrier and navigate its way through the tissue in the brain and find its target. And it has to only bind to that target and nothing else, and that's called specificity. And so these radio tracers have now been developed to the point where they can do that. And the PET scanner is like a big Geiger counter. It detects events that are happening in the tissue of interest, in this case, the brain. It's a big circular thing. And because the physics of this is that the positrons are emitted at a 180-degree angle. It goes left and right or up and down at 180 degrees. And that means you can pick it up on a circular PET detector, a PET scanner, and it forms an image from that. And so that's how we are able to detect this using this form of imaging. And it's really a remarkable methodology that has really changed the way we can think about Alzheimer's disease, to the point where now we can diagnose this and categorize this based on their imaging profiles. Do they have amyloid? Yes or no? Do they have tau? Yes or no? On an MRI, do they have neurodegeneration? Yes or no? So those are A, T, and N, and those are the key brain features of Alzheimer's disease, and they can all be looked at with imaging.
Right, right. And, speaking of the amyloid and tau PET scans, and in a study published last year in Alzheimer's and dementia, among other results, your team found that people who are amyloid positive, so elevated amyloid PET scan, for a longer time were more likely to have a faster cognitive decline compared to those without amyloid. Can you tell us more about that finding and other significant findings in that study, and why they're important?
Yeah, that study that you're talking about, with the first author being Rebecca Kosick and Toby Bedhauser, it's probably the most important finding of my career. And I'm so grateful to these two scientists for coming up with this. What it involved was, as we had a decade of amyloid imaging in the RAP study, we had people with 4 and 5 amyloid scans over 10 or 12 years. When we put all these together and just plotted the amyloid signal versus time or age, what we saw was that in the people who are amyloid positive, it was pretty predictable. Their rate of change was just like everybody else's rate of change. And what was where the variance was mainly in the age at which they crossed that line of becoming amyloid positive. And so from that observation, we developed a simple method of predicting back in time, back towards when they became positive. And that allowed us to estimate the age at which a person became positive. And we can also try to predict forward in time too. There's going to be uses for that down the road, but understanding when a person became positive is critical because as you said, the people who have been positive for longer are more likely to exhibit cognitive decline. And this, I think, helps us solve a big puzzle in our field, which has been that, well, a lot of 25% of healthy older adults are amyloid positive. And if you scan a bunch of 85-year-olds, it might be 40% of them that are positive. But what that doesn't tell you is, well, when did they become positive? And once you add that variable to the analysis, all of a sudden it becomes very clear. The longer you've had the amyloid in your brain, doesn't matter what age you are, the longer you've had it, the more likely you are to decline. And the other piece of that is that we've observed that a person could be amyloid, their onset of amyloid could be anywhere from age 45 to 85. That's a 40-year span at which someone can begin to develop this disease. And so now we have the ability to pinpoint that, when it happened, and improve our prediction of decline.
Right, got it. So you have a way to estimate actually when someone became amyloid positive in their lifetime, right?
Yes, yeah. We can estimate their age, we can estimate the duration that they've had amyloid in their brain. And we think this is going to be an important tool for our field to understand things like risk and susceptibility, and the other side of that, which is resilience and resistance to the symptoms.
Right, got it. And one quick question I wanted to touch upon then is amyloid disclosure, right? So with these findings, to the layperson, like if they find out that they're amyloid positive, like maybe it's probably kind of scary, right? So I wanted to ask you about RAP's work right now in terms of amyloid disclosure, because you mentioned it's important to create a responsible approach to disclosing amyloid status, yes. Right? So yeah, can you tell us more about your work in that area?
It's it's an important area that we are being hopefully very thoughtful in. We're developing strategies for disclosure, and we have a disclosure study in healthy people to help them understand their amyloid status. We think it's important to be transparent with these findings. But before we go in fully confident in what we found, we need to make sure it's replicable in other cohorts and that other researchers using their methods can observe the same thing. So we're doing it, but we're being cautious about it. We're being cautious about what amyloid means. We're not disclosing, for example, the age at which they became positive, because it's too new. That needs to be validated by other studies before we disclose that level of detail. But we are telling people if they're positive or not. We're assessing in this research study led by my colleague, Lindsay Clark. She's assessing how that information helps them make medical decisions and lifestyle and health decisions. And we are also disclosing in another, it's not a study, but it's a feature of our study. If a person has MCI or if they've developed dementia, we will disclose to them their amyloid status if they want to know. And we'll also let their doctors know if our participant allows that information to be shared, because it's helpful. In some cases, people with MCI, mild cognitive impairment, may not have amyloid in their brain, and their cognitive decline might be due to something else. And that's helpful. And it's also helpful to know the opposite. If you have amyloid in your brain and you have MCI, that means you're likely on a course towards Alzheimer's dementia, and that is also helpful. It's not very pleasant news, but it's important information.
Right. And adding to the mix of this then is the tau tangles, right? Because in a separate study, this was published in Brain, right? Last year, the main finding was that cognitively unimpaired people who with positive tau and amyloid were more likely to have a faster decline in cognition compared to those with no elevated amyloid or tau, or just elevated amyloid, right? Again, like, can you tell us, your thoughts about that study and why that's important to know?
Sure. Yeah, this was also authored by Dr. Toby Bedhauser, who's an assistant professor here. He's the first author on this, and this was RAP participants, and it was using the now almost 2 decades worth of cognitive information that we have on these participants. A number of them have undergone amyloid scans and tau scans, and in fact, that's what we found, is that those who were tau positive and amyloid positive had 3 times faster a rate of progression on their cognitive testing. And importantly, there weren't a lot that had MCI or mild cognitive impairment in that group, because our cohort is still very young. But we were able to detect these changes, or these differences in their rate of change in cognitive decline that are associated with aging during late midlife to early old age. It's incredible, and it's the value of doing the same tests over and over every 2 years, even though they are very unpleasant to our participants like Therese. Having that kind of stable testing allows us to look at these trajectories and come up with this kind of information that in fact there are changes happening well before the clinical symptoms or the clinical diagnosis of MCI or dementia might be given.
Right. So these studies really highlight why it's valuable to study participants over a long period of time, that we can gather this type of data to find these results, right?
Absolutely, yes. And it's these dedicated, wonderful RAP participants who are providing this information. And it's just, it is, you're right, it's that longitudinal component. It's the consistency over time that allows us to get this.
Right. And maybe last question then on the topic of amyloid and tau is that it's also not uncommon to find people with amyloid plaques and tau tangles in their brain. but they don't have Alzheimer's symptoms, even though they're older adults. Like why is that the case? And like, has there been any of that type of finding in RAP?
There has been, yes. We have people who have it but don't yet have symptoms. My opinion, and we need to verify this with further study, but it seems to be a matter of time. And it goes back to this chronicity idea or age of onset idea. The longer you've had it, the more likely you are to experience the cognitive decline. So that's the hypothesis we're testing now. And we need to know, and we want to know, what is it about our participants that might render a person more resistant to cognitive decline versus more susceptible. And I think it will shed light on this exact conundrum that you bring up, that there are people who pass away and under a microscope, they have plaques and tangles, but that microscope doesn't tell you any of that temporal information. And that's where our study can come in. In fact, if we know of someone who's amyloid positive in life, we could be able to tell how long they've had amyloid at the time of their death. And that may inform these neuropathological investigations.
Right. And yeah, some people seem to be more cognitive resilient, right? That's a term that
Yes.
that you use in terms of more cognitive resilient against Alzheimer's pathology, right? And yeah, and one of the studies called, in terms of looking at cognitive resilience, is African Americans fighting Alzheimer's in midlife, right? FAME, is that how you pronounce it?
FAME, that's right. Yes.
Can you just tell us briefly about that study?
Sure. This is a study by my colleague Carrie Gleason, who's a professor here at UW-Madison, and it's looking at our African American participants, not only in RAP but in our Alzheimer's Research Center, to try to address these questions that we've been talking about. And we know that there's certain things that seem to be more common in our African American participants: high blood pressure, higher incidence of diabetes, higher cholesterol, higher rates of high cholesterol. So what is it about these things that might render a person more susceptible to cognitive decline? These are things we need to know in this community specifically, so that we can do a better job at guiding them to maintain brain health.
Right, and that's just one among other studies in RAP that's looking at, brain health and cognitive resilience, right? I mean, you guys are looking at like social determinants of health and like physical fitness and so on and so on, right? So
absolutely, yeah. RAP it's NIH funded from the federal government, from NIH, and it also supports about 16 or 17 NIH funded linked studies at any one time. And yes, we're studying it from all angles: stress and cortisol, physical activity, communities, neighborhoods, area disadvantage index is something that our colleague Amy Kind is looking at. All kinds of things. And then we have a number of investigators looking at vascular disease itself and innovating in the space of how do we image vascular disease and how can we do it better than what the tools that we have now are telling us. So yeah, there's quite a bit of innovation happening in the study, and it's exciting to be able to support all of this through our study infrastructure and through our willing participants who sign up for these add-on studies. They're very dedicated people.
Right. And to wrap things up, then I want to bring the questions back to Therese. Therese, I was wondering, what were the main lessons that you learned about Alzheimer's research then during the filmmaking process?
Well, we learned about this whole issue of potentially the resilience factor, which gives people a lot of hope that there might be things you can do. And just in terms of some people who've seen the documentary locally in my community, in some sessions we've had to talk about the documentary, people people want to change their perspective on what they're doing. They want to be more physically active because they know it might, or they because of what's in the documentary, it could be a path to brain, wellness. So that's a very satisfying outcome if people start to think about lifestyle choices in light of this and other diseases too. We know heart is a big lifestyle choice potential. You can do a lot to impact your disease or lack thereof, with heart as well. So that was one of the things we were able to film as it kind of unfolded through the study. The early scenes of that exercise study were some of the, the early trials of that, and it's still ongoing. So that is a real positive thing. I do want to mention, and this is pivoting briefly off the documentary, but every couple of years, and the pandemic, of course, has affected this like it's affected everything. A group of the researchers in 4 locations in the state do an overview of their latest findings. Some of what Sterling touched on, with you today. And those are very invigorating because we get to hear, like Gina said, with her Milwaukee efforts and her CAB, when the researchers come in, it's like having the quarterback of the football team come and talk to you. It's a big deal, and you learn the cutting edge of what they're doing, and they give us, and they don't dumb it down. I mean, they dumb it down somewhat, but I mean, they speak to us in a way that, we look at the graphs, we see what they found, and that's very exciting, and that's a piece of what keeps people engaged, because if you just heard nothing or just got a newsletter, and the newsletters are fine, but the physical presence and the time to answer the questions after is very valuable. And I hope we can start doing those again soon.
Me too.
Because we really feel like we're more than research participants. And that means a lot. And that keeps people engaged. The approach of this research, I feel, and I guess I'd have to study it, but I feel it's unique and cutting edge in terms of the interaction.
Right. And that goes back to the point to Gina, right, in terms of engaging with the community and building that relationship, right? That's really what it's all about. How about, and I think you touched upon this as well, what do you hope ultimately people can learn from your documentary? And yeah. Sure.
As we put together our various cuts over time, we talked about that. What are the things that are coming out of this? Because it was filmed in real time, we didn't know. So the first one is the one we've been talking about, is the potential through healthy lifestyle choices to improve brain health. And that's pretty big. The other one, though, is when we look at the care that the Daniels family provided to their mother and the way they supported each other, we have to develop, like Gina's doing and has done in Milwaukee. There still has been, and at the time I started this and through the middle, there's still, after all these years, a stigma associated with this disease. And we have got to get rid of it, because we need to embrace people in our communities who are dealing with this and find support mechanisms where there are support mechanisms, but we have to help them get to them. And we have to have a more community-oriented approach everywhere. And that's a hard thing. But that's where dementia-friendly communities has come in through the past few years. And there are many cities across the country that have embraced this model to provide a better community support system. And then lastly, and very importantly, one of the gaps for research is people participating in a different kind of study, which is clinical drug trials. And we need people to feel comfortable participating in research, and get more numbers in the various drug trials that are going on. And that's an uphill thing. So we hope that by showing people participating in research, and that some people might be motivated to participate more in research. And it doesn't have to be a long longitudinal study. There are many opportunities for smaller studies of shorter duration with potentially less, less time. So those are our hopes.
Right. And is there any final thoughts, Sterling or Gina or Therese, that you'd like to add?
A big thank you to our participants for making all of this possible, and a big thank you to Therese for bringing for putting a spotlight on this study and on the dedication of research participants.
I'll second that, Sterling. I think definitely we can't do this without the community and the participants and their commitment over time, and allowing us the opportunity to serve them in this capacity. And then, of course, Therese, the brainchild behind your documentary, it's just phenomenal. And I think to your goals, I think you're reaching those just based on what you're saying and what we've heard, from the small previews. People really are responding and saying, that's me. And they're able to identify themselves in your documentary. And I think that in itself is a huge feat. So bringing the science and the community together is the way in which we're going to tackle this disease successfully. So thank you for just your tenacity. And I know it wasn't easy, but you did it, right? But it's for the benefit of the community. And so we appreciate you for that. And just thank you for this opportunity to share and having even Sterling and I being able to talk about this work with you. That's an honor for me. So thank you.
And Therese, where can people watch the documentary?
Well, the pandemic has not helped much there, but we're trying to do community screenings, and those are local screenings, and we have one coming up. We have a big goal, and that is to do a broadcast version that would make it more widely available. But that is a whole different world than the film festival circuit and community screenings, but that's what we're working on right now. So I hope that sometime in 2022, we might be able to get to a bigger audience. Fortunately, we have a distributor that was interested in us and that I signed a contract with earlier this year that has some good track record in this arena of getting to broadcast. It's a must. You have to have a distributor to get to broadcast. So I hope to be able to give you an update maybe later in this year on where people could see it on a broader basis.
Got it. And Sterling and Gina, is RAP still enrolling participants? And if so, where can people find, what's the best place to learn more about RAP and reach out to you?
We will we'll post updates about the documentary on our website, which is where people can also sign up and hear more about our study. It's rap.wisc.edu, WRAP.wisc.edu. And we are enrolling mainly African Americans and other persons from underrepresented groups. The study is technically still open, but mainly we're focusing on those groups right now.
Got it. All right. Well, thank you all so much for your time. It was a pleasure speaking with you.
Thank you so much.
Thank you.
Thank you very much.
Bye-bye.
Here.